Dear all, dear members of the Dementia Alliance International, my name is Alexandra Rauche. I'm working for WHO Rehabilitation Program, and I'm extremely happy to have the opportunity to share the perspectives of WHO in terms of rehabilitation for people with dementia. But first, I want to congratulate you to this webinar series, which is really a fantastic opportunity to share knowledge, experiences, and therefore, as said, I'm really happy to present on this occasion. Sorry that I cannot join in person, but I hope my slides will provide you with a lot of information about the work WHO is doing. So let's start with some thoughts about rehabilitation. I probably don't need to explain to you what rehabilitation means, but in terms of our definition, rehabilitation is understood as a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions. And this is important to take into account because our work is also in the context of universal health coverage, which is one of the overall objectives of WHO. And universal health coverage means that all people receive quality services that meet their needs without being exposed to financial hardship. And rehabilitation is one of the essential services to be included in universal health coverage. So it's very important to provide countries with support to implement and integrate rehabilitation in their health systems. And therefore, our specific vision, so the vision of WHO Rehabilitation Program is really that everyone who needs rehabilitation receives those quality services to optimize and maintain their functioning in everyday life. There is one thing that you need to take into account, that we think, or we want to send a message that rehabilitation must not be limited to people with disability in terms of people who have some sort of disability certificates. Rehabilitation needs to be available for all people who are in need and who experience any sort of health conditions. Now, what do we know about the needs in general and specifically in people with dementia? I want to refer to two very, very important materials that are available at our WHO webpage. First, the just recently launched Global Status Report on the Public Response to Dementia. I really want to encourage you to have a look at this document, and at the same time at the global estimates of the need for rehabilitation. And I will refer to both materials in my presentation. So let me start talking a bit about the needs in terms of prevalence and need for rehabilitation. In the Global Status Report, it is published that 55 million people around the world live with dementia. 55 million people. There is also a section on what is available in countries regarding guidance on clinical guidance, standards, and protocols. And only 58% in countries report that they have any sort of guidance, standards, or protocol how to address dementia. And here it is very important to keep in mind up to now, and also in this report, there is no guidance available on rehabilitation. So something that really needs to be addressed. Now, WHO Rehabilitation Program has published the global estimates of the need for rehabilitation. It's also important to take into account that both protocols refer to the global burden of disease data. For the estimate for rehabilitation needs, which was work together with the Institute of Health Metrics and Evaluation, we had a closer look into the years of lived with disability associated with living with dementia. So here looking into the bit more severe levels of disability, the estimate is that about 52 million people could benefit from rehabilitation because they experience a bit more severe levels of disability associated with dementia. This would mean that about 94% of the people who are diagnosed with dementia could benefit from rehabilitation, and that's a lot. And it's even getting more if we look into the last 30 years. There has been an increase of 260% of people living with dementia who could benefit from rehabilitation. And I want to share with you some more in-depth insights into those numbers. So here you can see in the figure in the upper part, this is a figure on the increase of the number of people who could benefit from rehabilitation. In 2019, it has been about 20 million people. And now, as mentioned, it's about 52 million people who could benefit from rehabilitation. When we look at the distribution in the world regions, you can see there is a big difference. While Western Pacific region has the highest numbers, followed by the European region, in the African context, the numbers are the lowest. And of course, we can understand that this relates to the age and the aging populations and the differences in aging in the different world regions. And here I want to show you with some more insights trends over the last 30 years. While in 2019, the numbers were much lower, we can see the increase in numbers was very different, with the highest increase of total numbers, again in the Western Pacific region, followed by the African region, and lower increase in the other world regions. But it's also important to not only look into the total numbers, but also into the rates, numbers per 100%. Because as you know, populations are very different across different regions. And here we can see the highest rates of people living with dementia who could benefit from rehabilitation we can find in the European region, again followed by the Western Pacific region and then the regions of the Americas. It might also be interesting now to have a more specific look into countries, because here now we understand why it's the Western Pacific region, and we can see that China shows the highest numbers of people living with dementia who could benefit from rehabilitation. But when we look into, again, when we look into the rates, we can see Japan has the highest rates of people living with dementia benefiting from rehabilitation. But then the European region shows the highest numbers, but also the Northern American region shows high rates of people living with dementia. And the last slide on numbers. It's also important to have a closer look in the country context when we look back to the last 30 years, and where we can find the highest percentage changes of people living with dementia. And again, it's China, but we can also see huge changes in these percentages in Japan. But also now, when we have a closer look at the American region, we can find high increase of percentage changes in South America, in the northern parts of South America. While in the African context, we can still find some countries, those in the light blue, where there was even a slight decrease in the numbers of people who benefit from rehabilitation. However, please take into account, with aging population, we assume that there will be an increase around the globe of people living with dementia and those who could benefit from rehabilitation. Now, we know the need is huge, but is the need for rehabilitation sufficiently addressed? So globally, at the moment, there are about 2.4 billion people who could benefit from rehabilitation. across all health conditions, and we assume the need will increase. But what we experience is that there is a low demand and a low supply of rehabilitation around the globe. And the low supply, of course, may relate to low capacity in relation of financial resources, but we also know that we face challenges with the rehabilitation workforce, that many countries do not have people trained to deliver rehabilitation. And at the same time, we also are aware that there is a low awareness of rehabilitation, what rehabilitation is, and what the benefits of rehabilitation are. So WHO is responding, and we want to make a change in this situation by increasing the demand for rehabilitation by advocacy and providing countries with technical support to increase the supply of rehabilitation in their countries. So therefore, WHO has initiated Rehabilitation 2030 initiative. And this initiative started in 2017. And we have developed 10 action steps. And of course, I'm not able to explain all the different action steps in this short time. So if you're interested, please go to our webpage. I have decided to only present or provide some examples for 3 of those areas. And I would like to start with the package of interventions for rehabilitation, which is one product that we are currently developing to address the implementation of rehabilitation in universal health coverage. So we are developing a package of interventions for rehabilitation to support ministries of health by providing information on evidence-based interventions. And in relation with this, the required resources that you need whenever you want to provide rehabilitation in your country. This information will help countries to plan, budget, and implement interventions for rehabilitation in their health systems. And here we also want to address the need to guide countries on what are the interventions that they should include in their health systems. We are developing this package for 20 health conditions which are the most prevalent, with the highest prevalence rates, and with the highest years of live with disability. So where there is the highest need for rehabilitation. It's not the exhaustive list, but this is a starting list. And as you can see, dementia is included in this list. And I'm very happy to inform you that we have just finished one step in the development process of the package of interventions for rehabilitation for dementia. So we had a development group which was working hard on developing this package. And many experts from all around the world representing the rehabilitation workforce that is essential when you provide interventions for rehabilitation in dementia, but also presenting the consumer perspective, work together in developing this draft package. And we will soon start a peer review process of this draft package to inform you the whole package we plan to launch early next year. Now I want to provide you with some insights. What is this package about? Don't worry, I know this is a very comprehensive table. I just want to provide this table so that you understand this package a bit better. So you can see this is just one example of the information that has been developed by our development group. And this shows the information for rehabilitation interventions targeting to maintain and improve functioning to address activities of daily living. So you can see the development group has agreed on a number of interventions that are essential when the performance of activities of daily living should be maintained or improved in people living with dementia. And then you can see the additional information, so they have specified a target population, They have worked on describing the material resources that are required and at which service delivery platforms those interventions should be available, but also the time that is required per unit. So that is very specific information, but I hope this helps to better understand what this package is about. Now, this kind of information will be available for 18 domains. So the development group has decided for those domains which are relevant to people living with dementia, there will be 69 specific interventions. And you can, at a quick glance, you can see many different domains that are relevant to people living with dementia and where rehabilitation can make a difference. Again, this will be peer reviewed, so this is not the final version, but we will start the peer review process soon. As we know, this kind of information is not enough when countries want to implement rehabilitation in their countries. We know there is a huge gap when it comes to the rehabilitation workforce. So therefore, we have already launched a rehabilitation competency framework to ensure that in the future, the rehabilitation workers will have the competencies to deliver this care. And this competency framework provides information on the knowledge and skills that are required to provide rehabilitation interventions. And this framework will help countries to develop their own local competency frameworks. And when it comes to implement rehabilitation in countries, there is another important tool that we have already launched, that is the Guide for Action. And that is a strategic planning tool that helps countries whenever they decide to implement rehabilitation in their countries for specific health conditions or for several health conditions. And this tool provides different, more specific tools how to do a situation analysis, strategic planning, monitoring and evaluation and implementing of strategic plans. And just to let you know, the package of interventions for rehabilitation will be integrated into those strategic planning because it provides all the relevant information that countries need to know for strategic planning. Let me summarize. The need for rehabilitation for people with dementia is huge already now, and we all know with aging populations, it will increase across all world regions. WHO Rehabilitation 20 agenda has realized this, and we are working hard to develop products to support countries to strengthen rehabilitation in their health systems. However, we cannot do this on our own, and specifically when it comes to advocacy, to raise awareness on the need of rehabilitation, but also on the benefits of rehabilitation, we need to work with our stakeholders. And I can tell you, we are extremely thankful that with stakeholders like the Dementia Alliance International, but with many other stakeholders, we are already collaborating in developing those products, but also in advocacy. And we need to strengthen this in the future, and we are extremely happy to strengthen this collaboration in the future. And again, we would not be able to do this. I can just give an example. For the development of the package of interventions for rehabilitation, until now, we are collaborating with more than 500 individuals, which have been nominated by all our different collaborating partners, coming from more than 80 countries. And this is a fantastic collaboration. And again, I want to thank you and encourage you to also contribute with this. There is one opportunity, and I spend some time, I leave this slide here, because this is also a call. So if you are interested in joining or collaborating by becoming a member of the peer review of the draft package of interventions for rehabilitation, please contact me and you will receive all relevant information. everything you would need to know if you would be interested to become a peer reviewer of the package of interventions for rehabilitation. Let me again thank you for having the opportunity to present here. And we really look forward to continue the collaboration with Dementia Alliance International. And again, I really want to congratulate you with this approach with the webinar series, and I wish you a lot of success with this series. Thank you, and we keep in touch.
Alexandra, I think, talked about the needs of people with dementia for rehabilitation, and I guess the WHO kind of push to get countries to implement rehabilitation. We've been thinking about this here in Australia, and what I'm going to do is spend the next 6-7 minutes kind of sharing, I guess, our thoughts about, how to make it a reality. I'd also like to acknowledge the traditional owners of the land on which we meet, which for me here in Sydney are the Gadigal people of the Eora Nation. I'm not going to present a lot of data, but I haven't just made this up. These ideas are based on lots of conversations, interviews with people with dementia and their carers, interviews and conversations with policymakers and also clinicians and aged care professionals. And I just acknowledge, I guess, the groups who I work with. So over this webinar series, I think that people that we've been talking about how people with dementia should receive rehabilitation. It's a human right, and there's strong and growing evidence about the benefits of rehabilitation. So I'm not going to cover that again. We're going to talk about, what I really want to talk about is this big gap between what we know and what's happening in reality, that almost no one with dementia, once they get a diagnosis, is offered rehabilitation. And think about how we kind of start to bridge this gap. And I think we really do need to bridge this gap, because as a clinician, like, just kind of making this huge leap is really scary and very difficult, I think. And there's lots of reasons why we've been kind of exploring those barriers to implementing rehabilitation. And what we really want to do is build this very strong bridge, a system that supports rehabilitation as standard practice, which I think is what Alexandra was talking about, in her presentation as well. So what are the stepping stones to getting rehabilitation as standard practice for every person with dementia? We've been thinking about the groups we need to influence. So the first group is actually people with dementia and carers who don't know that rehabilitation is a thing, don't know you can get it, very scared about, I guess, talking about it. So, getting the information out there about what rehabilitation is and how you can get it and how it can benefit you. For people with dementia and their supporters. The other group we've been working with closely here in Australia are policymakers and implementers. So, for example, our Aged Care Royal Commission last year? Yeah, so the reports are suggesting that we need much more allied health in home care and in residential aged care. So there's that policy there now. So we're slowly kind of starting to affect policymakers and implementers. We've been trying to suggest that people with dementia are given a GP chronic disease management plan, which they can do already. It's within the rules. It just hardly ever happens. So kind of listing dementia as chronic disease, which should get a chronic disease management plan, which then gets you access to 5 allied health visits, that makes a difference. So we need to influence policymakers and the people who implement policy as well. So there's health service administrators in all kinds of sectors. We know that people with dementia, if they have a fall or end up in hospital, are less likely to get rehab, like for that other condition, not for their dementia, but for their fall or for those other reasons. There's also the medical specialist teams, the medical teams that make the diagnosis: geriatrics, older persons mental health, neurology, and rehab teams. They all operate slightly differently. They have a different culture. And again, we need to message to them that either those teams need to provide rehab, or they need to figure out how to refer for rehab. And I think there's different appetite in terms of kind of that psychosocial and, you know, non-pill treatment in those teams. I've been very interested in how aged care services also influence whether someone gets rehab. So aged home care package case managers and care coordinators, again, people can use their funds to get rehab, but do they? Does anyone suggest it? It's unusual for that to happen, I think. We know that in our new aged care system in Australia, aged care assessors will kind of help write the care plan. So are they suggesting rehabilitation? Again, I think our policymakers have said that, you know, aged care services should be provided in a reablement model, but whether that actually happens and how professionals kind of treat people with dementia, I think we need to work on. Really, that it's a very standard practice that if you're working with someone with dementia, you think about rehab and you think about how you put it into that practice plan, their care plan. Allied health professionals, you think that this would be a no-brainer, but actually allied health professionals here in Australia, they might get very little training about dementia. They find people working with people with dementia a bit scary, not because people with dementia are scary, but because they don't know what to do, because they have had little training. And so it's unknown, I think, to provide rehab for people with dementia. And we need to influence those allied health professionals, upskill them and kind of help them be more confident in supporting people with dementia. GPs and practice nurses here in Australia, GPs and practice nurses are the gatekeeper to services. I think that ongoing support of people with dementia really falls to the GPs unless you have a good geriatrician. So the GPs really are the cornerstone of, kind of getting universal rehab for people with dementia. As I said, we've been pushing for GPs to think of writing a chronic disease management plan for people with dementia, which gets them 5 sessions of rehab a year. It's not a lot, it's not enough, but it's better than nothing. It's definitely a start, I think, if you don't have private health insurance. So like I said, there's different groups and we're starting to think about how we message differently to these groups. So we're saying to people with dementia and carers, ask your health practitioners for rehab. We're saying to GPs, provide rehab, use a chronic disease management model plan. Health for allied health practitioners, you need to develop knowledge and skills for working with people with dementia. So rather than just saying we need to give dementia rehab for all people with dementia, we've got much more, I guess, specific kind of targeted messages, so that these are the stepping stones to a system where everyone knows. Because the GP will say, well, I can't find an allied health professional who knows how to treat someone with dementia. Or the person with dementia will say, well, my care coordinator doesn't know what I'm talking about. Like, they don't know how to do this for me. So we need to put all those stepping stones in place to build a bridge across that gap. Very quickly, I'm going to talk about Forward with Dementia, our website that Kate and other people have been working on. The Dutch and Polish websites have launched. The Australian website theoretically isn't live yet, but you can sneak a look at it. You can see it now. There's still a few bugs, but if you go to the Australian website, you'll find most of the content there. And please write to us and tell us if you find problems, because we're still, we're on the final stretches of going live with that. So that's forwardwithdementia.com/au. This is what it looks like. There's 3 sections, a section for people with dementia, a section for carers, and a section for healthcare professionals. And there really is an emphasis on rehabilitation strategies and therapies, including very practical kind of suggestions on how you get services. It's also got the parallel kind of messaging for healthcare professionals on how they support people, to get supports and services after diagnosis, and that they should put that into the care plan. So to close, I guess, it's really scary, I think, if I put myself in a health professional kind of shoe to start to provide rehabilitation for people with dementia. It's not standard practice, it's an unknown. And I guess your hands, all our hands, can help people, step across that gap for the first time. And once you've done it once, then you're like, oh, it does work. it makes sense. And so I guess that's how we see kind of, building this bridge between knowing that rehabilitation should happen and works to making it standard practice. Thank you.
That was a very good start now with from WHO, Alexandra, to talk about so much action being put into rehabilitation and pushing it to make it under the universal health coverage, which is make it rehabilitation as available, can be easily available to everyone, and it's not people are not able to get it because of the cost. Yeah. So and then Lee-Fay just shared with us the advocacy that we need to do for different target at different this is just like a business plan, target different customers and clients, how do you present your facts so that they feel that what is it in for them, yeah. So thank you for sharing that. Really give a very insightful way of how we at Dementia Alliance International can do our advocacy more effectively. Yeah, so this for me, my section is to share, because I come from I'm an educator and advisor on disability, and for me is that while all these things are going to put in place, there are still so much things that we need to do while we wait for all this policy to be in place. So there are things that we can do on our own as a community also, on how do we make ourselves, people living with dementia, to maintain our independence longer, our ability, and today this is my sharing, and I use it from my experience, how I use it for myself, and also from my work on disability. So yeah, I'm very proud to showcase the photo taken by one of our DAI member, Rob. I always use this my presentation to showcase the work of people living with dementia. Now, a big part of this dementia, living with dementia, is the functional decline and also behavior change for people. And both of these is a cause of a disability, and also, especially for the functional decline, it really increases our dependency on our family members or care partners for some people. So, but unfortunately, based from my own experience, is that there is hardly at least from in where I'm from, that is from Singapore, there is this lack of intervention that really target on helping to maintain that functional capacity of people living with dementia, and without that, it doesn't, without that intervention that put in place, it really doesn't help to, it's not able to delay further disability caused by dementia. So that is one thing that I found, that living with dementia is very can be very difficult if there is no such kind of intervention or rehabilitations put in place. So because I as I said, I work in disability, I work with helping learners with disability. So I saw there is these similarities between what I used to, the ways of how I support my students, and to what I'm experiencing. So I sort of use that one and put it over for myself. So that every day I can still maintain my functioning, get around and do my things. So this is how I see myself you know, throughout the lifetime, our brain changes, and it changes the most, I would say, compared to any parts of the body. And then as we age, like it or not, you know, our ability, our cognitive ability also change. But that is more in the processing speed. We tend to not so fast as compared to our younger days when we come to thinking or even for reaction to certain things. Now, but there is something happen along the way for me when I have my what is that called? Meningitis. Yes, I have a meningitis when I was 30 years old, and at that same time, and it almost killed me because it was wrongly diagnosed for normal pneumonia and things like that. Yeah, so by the time I was admitted to the hospital, it was in a very critical state already. And at that same year also, I was diagnosed with very severe endometriosis. And so both really attacked my whole body system. And at that point of time, I was in Malaysia, and there was no ideas of changes that you experience from all these things happen to your brain is unheard of. Yeah. So after I recover from my meningitis, I noticed that my memory is no longer so good, and I start to have issue with some of my executive function also. So, but then, you know, because there is no proof or things like that, so I cannot link it to the meningitis that I have that almost kill me. Yeah, and then I also have the total removal, the BSO, whereby all my ovaries and everything was removed. And so that means that I don't have any more estrogen since 30 years old. Was put on what do you call hormone therapy, hormone replacement therapy, but my body reacted to it and started to develop lumps on my breast, so it was terminated. So after that, I'm just on my own. You know, my brain function without the estrogen protection for the neurons. Yeah. So, but then these changes is very subjective. It's only I feel it. I feel the difference, and I have been trying to talk to my GPs and doctors about the changes that I experienced. But because it's very subjective and it's very hard for other people to I mean, even the test would not be able to indicate that, yeah, you have these changes. So I was able still to cope with it. It's just that from my baseline, I have dropped. And then when I come to my 40, my early 40, that is where I start to find that, you know, I have more than one area or one or two area, but I have more area now with my executive function. And I also start to have, you know, my behavior change. I tend to become very, easily irritated and agitated. And that really affects my relationship with my husband, because I easily get into argument with him for very, very small matters, and they cannot understand what is happening to me, because, you know, I'm not that kind of person, because I work in special needs. I know all the disability. I work with saving the children and for the underprivileged children. So I'm I'm not that person who can easily get irritated with every little things. So nobody can understand, and I also cannot understand. I doesn't like my new self, what is happening to me. So the only reason that, or the only explanations I was given is that I'm having a mood swing or some kind of emotional problem, depression, or things like that. So that was that is where, only now when I diagnosed with dementia, I start to look back now. I say, oh my God, that was when I was have mild cognitive impairment, which now is called mild neuro and cognitive disorder. So imagine if something can have put in place that intervention at that point, or even earlier when I have subjective intervention, I might possibly delay the onset of my dementia. So, and when now I found myself living with dementia, which is under the new title called major neurocognitive disorder, I found that I have a lot of disability that I used to work with my learners in the disability, like attention, executive function, and language and things like that. That is where I start to find there is a similarity between disability, and when I come across that WHO said that dementia is an acquired form of disability, and also heard from Kate that about this thing. Then I start to say, okay, it's confirmed that that my this feeling that there is so much similarity, because I could see myself like the way I see in my learners that I work with. Yeah, so that is where I start to put intervention in place, because I don't get for us here in Singapore is that even if you want to pay for rehabilitation, it is almost impossible for you to get access to rehabilitation or intervention of any kind. When I experience so many falls, I asked to be referred to get what you call physical therapy, or somebody just to help me to minimize my fall and things like that. I was not given. And then when I was having choking and things like that, I asked to be referred to a speech therapist to help me and with my language. It was only after mass persuasion I was given the referral to go and see a speech pathologist. Yeah. So it is very difficult. So then that is where I decided that, while I do my advocacy, while changes is going to happen, our life and our cognitive changes and impairment, it is still ongoing. So we need to be more proactive in helping ourselves. So that is where I put the compensatory strategy in place to help myself in these 4 areas. So what is this compensatory strategy? Is basically a behavior. It consists of 2 parts. It's about your behavior change, the way you do things, because of the changes in your cognition or your functional ability or your behavior, you cannot do the same thing in the same way. So, and then it also involves environmental changes. You have to change some of your environment to enable you to able to execute the task. So with the behavior strategy, the change in the way you do things and the environment modifications, you are able to bypass, the impairment, or at least minimize the impairment, and so that you can continue to do the work. So when coming to, so what is this environmental modification? Well, it's very simple, it can be anything like, a kitchen timer. That is environmental modification, which you depend on something in external devices to help you to compensate for your impairment. And then, like for example, you can use a checklist also to cross out the tasks that you need to do. And then when a checklist, a checklist will also be considered as not only as a environment an external aid, but it also talking about the habit. If you have never used a checklist before, it is area that you can consider to help you, a change of your behavior. Now, working in a clutter-free place, that is really about your environment modification. Like for me, when I work in, whether is it my advocacy work, when I need to use my laptop, or when I do my cooking, I had to make sure that my worktop is very clutter-free. Only the things that I need can be on the table, or else I will not be able to sustain my focus. And then, so the ways to support would be, for your executive function, that is something that you can find ways to help you to maintain your attention. And then for your communication accessibility is start as soon as early if you have language problem, and get your family members to understand and what are the strategy that you can use, like picture card and things like that, for later on when you are no longer able to verbalize, have articulation problem. And then where to support your everyday living activity would be, looking at how the impairment, whichever impairment that you have, and then see how that restrict that activity, the everyday activity that you're doing. And what we want to do is that we don't want our impairment to so-called restrict our participation, that we can still go around every day to do our everyday activities. And when we talk about physical function and support mobility, it's not just about getting around, but it's also about your vision and sight and hearing and spatial orientation. So all this that strategy you can what you call put in place. So okay.
Thanks, Emily.
So this is just a wrap up what you call a quote from Ed Williams, is a coach, and said that I'm not telling you that it's going to be easy. No, it's not easy, and you need to be very what you call motivated into doing it, so that you can put it in place, because your motivation is the primary factor of how you are going to live well. Yeah, thanks.
Good morning, everyone. Thank you for the privilege of allowing me to speak at this important DAI webinar, number 4 in the series of rehabilitation for all people with dementia. Testing to get a diagnosis takes far too long, and the questions are all outdated. In the meantime, there could be a fact sheet available to clients to suggest and encourage a simple task as walking to commence immediately as the beginning of a rehab program. Instead of only being advised to go and get your end of life affairs in order, or in my case, I was also told, go to the police station and register with them in case I got lost. Rehab also needs to be made more accessible in regional areas. The diagnosis process also does not account for disabilities in terms of how much time it takes me to do some tests. E.g., I might get a near perfect score, but it takes a very long time to complete. Social interaction in residential care is not encouraged, and there is too much sitting, doing nothing, or only boring activities as the good old bingo, but occasionally we might get a word game once a week. Woohoo! Rehab after testing is so important, otherwise we slip through the system. However, any rehab needs to consider other disabilities or injuries, as I am often expected to do things that I've not been able to do due to my childhood injury. They don't really take my disability into allowances when recommending physio. I am sometimes made to feel my inability to do something is in my head. I realise because of lifelong rehab following childhood accident that to make people with dementia wait for it is too often happens to deny us rehab is doing us more harm no matter what age we are. Compare it to how hard it has been to fight for any rehab with dementia, including the speech therapy. It took over 6 months for any support. Also, if I hadn't been personally motivated and kept pushing for rehab and exercise, it would not have happened, as no one seems to think it's important. When I first came into residential care, it took over 12 months before I got on the physio program. Terrible. The staff need educating in the value of rehabilitation and the value of something as basic as everyone having regular exercise and understanding all types of dementia. This helps with things such as motivation, mood, and energy, as well as reducing the risks of conditions such as heart health, diabetes, cancer, falls, and coordination problems. It significantly improves my quality of life and well-being. I even had to send a formal complaint letter about being denied walking in the community for exercise, which ended up on the Federal Health Minister's desk before they responded. This has helped the staff see that we all have rights, even people with dementia and living in residential care. Even now, with the current lockdowns, staff have now started saying, this is your home. You have rights and you can go out for exercise. This was not happening before my formal complaint. I'm not sure if this has impacted on other residents though. Where there's a will, there's a way. And by keeping active and continuing to engage in my community, this is the best type of rehab I can have. I can and I will. As we have learned from this series of webinars, the research is clear. We must be provided not only with rehabilitation, which has benefits such as reducing and preventing falls, we also need adequate pain management. And I'd like to say thanks to all my DAO family for the fantastic support they give us. And I'd just end with the quote from Maya Angelou. My mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humour, and some lifestyle. And just to finish off as well, the biggest challenge is that almost nothing has changed since Christine Bryden started advocating in the last century. Thank you.
I was really privileged to be at the very first WHO's Rehabilitation 2030 Forum in 2017, and then again in 2019. And then, of course, life changed for all of us thanks to COVID. So they've been online forums, but actually that's made it more accessible for people to be able to attend, because you don't have the cost constraint to get to Geneva. So I really loved this quote from a doctor from the Ministry of Health. I've forgotten where he was from, that he keeps the patients alive and rehabilitation gives them quality of life. And most of you will know I've been campaigning for rehab for people with dementia for quite a long time. So to have been involved in the WHO guidelines that are being developed now has been exciting for me, and Lee-Fay is also on that, in that group. But, you know, we could look at lots of reasons why it's been denied to people with dementia for so long. You know, I can remember an expert telling me at a forum many years ago that, you know, it's a waste of time to even think about giving people with dementia rehabilitation. And yet I know that my own functioning has only been maintained as well as it has because I've been able to afford rehabilitation in every domain of my dementia. And I think there was a comment in the chat box from John Quinn. You know, it's great if you can afford rehabilitation, but it shouldn't be only available to those of us who can afford it. It is a human right for everyone. I think the other thing that I think would really help the rest of the world is to actually reframe dementia as a condition causing disability, which the WHO have been doing for a very long time. But it does help to reframe it in a way that ensures that our rights under the Convention on the Rights of Persons with Disabilities can eventually be applied. So my hope is for that to happen as well. So thank you very much, everyone, for being at this webinar today.